Hello, everyone. Welcome to week 2. This week, we're going to be going over behavior therapy and cognitive therapy as well. So to start off, behavior therapy is the ideas about how human actions and emotions develop through learning. And the most popular client that you're going to have with behavior theory are children and adolescents, as well as adults who have cognitive and intellectual disabilities, because they are still at that same age range as a child and adolescent. Now, I want you to think, why would this work with just children and not mostly adults? But what I want you to think about is how we mold our children and the behaviors that they acquire. So, for example, if a child is living in a drug-infested environment and the only way they know how to gain positive attention is by having a temper tantrum, this may be actually used throughout their entire life, well into their 20s, to their 30s, to their 40s, until maybe at some point in their life it's not working for their spouse or in their job or some way that it's hindering them, that they come and see you. And you finally are figuring out that this is the behavior that they've learned and they've been using it their entire life. So for them, they don't understand why it's a problem. Now, there are some theories that come from behavior theory, such as opera conditioning, classical conditioning, social learning theory. Those are some theories that are kind of a branch off of behavior theories. And these theories thrive on behavior and how it can shape a person. The concept of nature versus nurture is big in behavior theory because some believe that the environment creates the person's response, and others believe that it is in their genetic makeup. And it is only to avoid pain and to seek pleasure. So there's a big argument out there, as there always is, between nature versus nurture, but especially in behavior therapy, it's wildly used to figure out, is it the environment that shaped this client, or is it their internal clock that's telling them, hey, if I do this, this is going to create pain for me, so I'm just going to do this so I can get pleasure. That's the difference. So for those of you who have children or have grandchildren or have even babysat before, think about when a child does something to violate the rules that you have set. The way that you react to their wrongdoing shapes their behavior. So how they respond to that situation after you've shaped that behavior is key, because the next time that they have that thought process of doing that same thing, it's going to be brought back to what was done to me before. Was I put in timeout? Was I grounded? I couldn't go out with my friends, or whatever it is that you put that punishment in. They're going to remember that, and that's how you shape their behavior to create that this is wrong, this is right scenario. So using behavior theory will most often be, like I stated earlier, at a younger client. However, you're going to meet grown adults in their age that have had no intervention done. So these are clients that are going to come across, they're having severe issues in their relationships. They don't understand why, because their entire life they've acted the way they have when they were 6 years old, and mom and dad maybe didn't pay attention to them, and the only way to gain attention was to have a temper tantrum. So for them, when they're having a big temper tantrum at the age of 30 and their spouse isn't responding well, they don't understand, because they think, well, what do you mean? This is in their head. This is how I've been responding my entire life. There's never really been a problem. Now there's a problem with you. That client is going to now think that the problem is really the spouse and not them. And that gets us a little bit into cognitive theory, but we're going to talk about that in a few moments. So using the behavior therapy technique can be actually really challenging, because most of the time your clients are not going to respond positively. They're actually going to respond very negatively, because you're going to be pushing them. You're going to be pushing them to think differently, to act differently, and it's going to be an uncomfortable action for them. So they're going to give you a lot of resistance. So this is where the client and social worker relationship comes into play, and it's extremely key, because if you have a strong relationship with your client, they're going to continue to work with you even though it is uncomfortable. They trust you enough to have you guide them through the stages because they want it and they trust you. If you find that your client social work relationship is weak, this is where you're going to find them pull away. They're going to pull away from you because they're going to feel like all you're trying to do is change them, and maybe you don't like who they are, or you don't accept them, or you don't mold well, you don't understand what situation they've come from. You're going to find every defense mechanism in the book that's going to come out. So that's why it's extremely important before you even start these types of interventions to really establish that client social worker relationship that we've been talking about for the past few weeks. So, before we intervene, we always want to assess. And on page 153 in Walsh, I think he gives some great examples of questions you could use in your sessions about behavior to ask the leading question so you can gain more information about what is causing the behavior, how is the reaction of others to that behavior, and how the client themselves sees that behavior. So in closing on behavior theory, it's very empowering and it assists in the process of change. Now, as in every theory, there's going to be a criticism to every single theory that we work on. And in the field, you're going to find that certain clinicians gravitate toward more certain therapy types and theories than others. So a lot of people will disagree with this type of theory because they find that as we're about to move into cognitive therapy, they feel like it's more of the cognitive. If we fix the cognition, then the behavior itself will change. And others feel like if we fix the behavior, then the cognition itself will change. So as you see, there's an up and down with everything. So it's really about yourself as a clinician, and feeling what you feel is best for the patient is really key. So we can't always be with the client 100% of the time. And that's where the criticism comes from behavior theory, because it's very reinforcement is huge in this type of therapy. And, we only get maybe 45 minutes to an hour a week with them, or sometimes twice a week, and we can't be with them 100% of the time. So this is where they feel it. That's where criticisms feel that the theory lacks, because reinforcement is so huge. And if we can't be there to reinforce the behavior, then it won't set, and the behavior could come back. So moving on to cognitive theory. So thinking of behavior, which we just moved from, cognitive theory is a way that you think about which is why the behavior occurs. So cognitions are the way that we know our beliefs, assumptions, and expectations and ideas that shape our perception in life. So an activating event produces our thought, which is our cognition, which then produces an emotion, an action, which is our behavior. So this is why these two are very interchangeable with each other. So now as we develop now as people develop and we create our own mind, we develop schemas. So a schema is something that's in our own head, and everybody's schema is completely different. So everyone in this class has a completely different schema. So schema are defined as our internal representation of thoughts, actions, and the world itself. Because of schemas, we organize our thoughts and feelings in certain ways, and we're biased because of our own perception of the world. So schemas are obviously our thought process. So even, for example, when somebody has a different view of religion or a different view of politics, it's because we have our own schema. We have our own bias on the world. So for us, in our world, our schema is 100% correct, and nobody else's schema is even close to what ours is, because we are 100% correct. So a lot of your clients will hold on to this, because when they come to you, some of them you'll be breaking. I always look at it as a visual picture. They're a rock, and for the first time, you're kind of tapping on them with a hammer and trying to break that mold that they've created with themselves. And a lot of them don't like it, because you're basically, in your therapeutic way, trying to get them to understand that the way that they've learned for the past 40 years of their life may not have been the correct way to express themselves, and which is why they're having such a hard time. So for them, that's a really hard thing to understand, because their schema has supported them through that time. And now you coming in as the clinician is saying that, you're challenging them. That's really difficult for them. Now, on page 178 in Walsh, he gives great examples of cognitive distortions. And I want you to think about which one of these that you use yourself, because as clinicians, we need to know our own cognitive distortions about ourselves. so that we don't impose them on our clients as well. And I think it gives great examples because it relates it to class, which everyone's currently in right now. So you're able to really see how the cognitive distortions affect you and how they truly can affect a client as well. So in cognitive therapy, you're going to be battling these cognitive distortions as well, because this is their defense mechanisms going up and them saying, wait, hold on, they're telling me something different. I've known this my entire life. And their negative thinking is going to come right in. So this is, once again, why I bring up the client and social work relationship, because it is extremely important. In cognitive therapy, the social worker is known as the collaborator, so of goals, of objectives, of interventions developed with the client input. So in cognitive theory, social workers can be seen as a model of problem solving leading to reasoning. So in cognitive therapy, clinical confrontation is huge, because you're going to have clients say, well, this is what I was thinking, but then they'll tell you what they did, and you'll find that the thinking doesn't add up to the action. And that's where the clinical confrontation will need to come in. They need to point out that they talk about this process of thinking. However, their action that they've just described to you is completely different than the cognitive thinking that they just explained. And you're going to see their face change, because for them, they've never put that together. So clinical confrontation is huge in cognitive therapy, because they're going to need you to assist them and guide them. And they're going to push against you a lot, because once again, you are going to be that person that's telling them that their cognitive thought and their action that they've been doing is wrong, but we need to continue to relate back to, this is the goal that you've set, this is what you want to do, and relate it back to what they've talked about with you. So this leads us into cognitive restructuring, assisting our clients in the process to process the wrong cognition that they've developed. So on page 181 of Walsh, she also gives an excellent example of the ABC model and method and how to apply it. So really pay attention to that, because I think he gives a great example of how, especially patients who are depressed, can think. So a criticism of this theory, as there is with every single one, is that cognitive therapy only focuses on the conscious, the thought process, the here and now. And some theorists think that cognitive theory just puts a Band-Aid on the problem, because the real problem is in the unconscious thinking of what we're all hiding. So that's why some theorists don't really believe in cognitive theory. So I want to touch on DBT for a moment, because it is huge in the social work community as well. So this is a combination of behavioral therapy and cognitive therapy. So most often it's used with your borderline patients and your severely depressed patients. This is due to their lack of interpersonal self-regulation and their likelihood to acquire adaptive behavior skills by personal and environmental factors. So that's the major difference there. I really encourage, if you have a patient who is severely depressed or severely you feel has great borderline tendencies, to make a referral to DBT if you feel as though you yourself aren't competent enough to handle that. I always say we need to acknowledge our own faults as well, so that we can benefit the client in their own setting. So in your practice, you're going to you'll absolutely use these theories, because you're going to be addressing their cognitions as well as their behaviors in your presence. So I want you to start to think about your own style and how it can work for you. So now, if you're watching this video, what I want you to do is email me your favorite ice cream flavor, and you will be able to get an extra point that you can use anywhere in the class that you lose a point. You'll just have to email me and let me know this is where you want to use your point. Okay? So I hope everybody has a great week. If there's any questions on anything I've said or any of the assignments, please feel free to let me know. All right, everyone, have a great week.